Welcome, everyone. I'm Professor Awobusuyi, the head of transplant unit of the Lagos State University Teaching Hospital, and I'll be discussing pre-transplant recipient assessment for kidney transplantation. This is a very important process, and the fact that kidney transplantation is considered the optimal therapy for end-stage kidney disease patients who are considered fit for major surgery and for chronic immunosuppression. It improves survival compared with dialysis, and the quality of life of most patients after transplantation is improved when we compare that with dialysis. There are also other benefits, and this includes the cost effectiveness, the cardiovascular benefits, and also socioeconomic benefits that are inherent in the transplant process. So evaluating the patient is pretty important and crucial. A number of factors affect the survival of the transplanted organ, and this include the presence of antibodies to the HLA antigens in the patient's serum, the type of donor kidney, donor disease, the primary disease that caused the kidney failure in the first place. All this affects the lifespan of the transplanted kidney, and in the evaluation of the patient we critically assess all this and determine which one is best for the patient, how to minimize the risks posed by these factors. Looking at the transplanted patient, three important conditions are predominant in the causes of death in those patients, and these are the cardiovascular diseases, infections, and malignancies. These are the three major causes of death in the transplanted patient, and in the process of evaluation of the patient we take steps to minimize risks that are posed by these major causes of mortality. So the predominant goals of pre-transplant recipient assessment are the evaluation to identify patients who will benefit from kidney transplantation and in whom the transplantation activity will not compromise survival. We also evaluate and develop strategies to minimize peri and post-operative complications, and to ensure that the patient is well educated before the surgery, and the risks and benefits of transplantation are explained to the patient, and the overall goal is to ensure a successful outcome for the patient. Not all patients will benefit from kidney transplantation. Some patients have substantial risk of perioperative death, and for instance, a patient with severely compromised cardiac function may not benefit from transplantation because of the high risk involved with the operation process. Patients who have limited life expectancy, generally less than 5 years, we don't usually consider them for transplantation. Patients with active infectious disease, active disseminated malignancy, and patients who are deemed non-compliant, who will not adhere to the anti-rejection drugs, we typically are very we usually consider them, and we don't usually proceed with transplantation in such patients, except we can modify the risk behavior, and patients can show good evidence that post-transplantation they are going to be adherent, they are going to adhere to the drugs that we use. For the assessment, we do a baseline workup, which includes biochemical profile, including the electrolytes, urea and creatinine, liver function test, blood glucose, and all this we perform routinely for all patients that are coming in for renal transplantation. We do chest x-ray to evaluate the lungs and any disease that could be picked up by the test, and we treat when amenable to treatment. We generally group and cross-match 3 pints of blood in our unit for the operation, and we do additional tests as required, Doppler scan of the iliac vessels, for instance. Some are routinely done, and may do pulmonary function tests. As we have said, cardiovascular death is very common in patients who are transplanted, constitutes about 30% of deaths from functioning grafts. And so the pre-op assessment is very important. And however, the problem is that we do not have guideline recommendations that assist us in patients who are not high risk, but there is a general consensus that cardiovascular assessment is required prior to renal transplantation in high risk patients. And the American Society of Nephrology and the American Society of Transplantation recommends non-invasive cardiac stress testing in patients who are more than 45 years, women more than 55 years of age, and those with diseases that are listed, in what we have on the screen, hypertensive patients, smoking, and so on. If the non-invasive test demonstrates ischemia, that an angiography is recommended, and if possible, revascularization prior to transplantation will be done. Evaluation by a cardiologist is important when required, and appropriate intervention is instituted. In patients who have cytomegalovirus infection, or patients are generally screened for that, Epstein-Barr virus, varicella zoster, hepatitis B, C, and HIV infections are generally screened for. Patients who are negative for hepatitis B are vaccinated prior to transplantation, and those who have varicella zoster virus, varicella zoster virus antibody negative. HIV positive patients must have undetectable viral load and a CD4 less than 300 and no HIV defining medical condition. Patients who are otherwise eligible for kidney transplantation and have evidence of chronic hepatitis B, C, or HIV infection are treated. Potential recipients are also screened for tuberculosis and are treated prior to transplantation. Cancer is common in end-stage renal disease patients, about 2 times as common compared with the general population. In general, we screen female patients that we do a pap smear, and we do mammogram if they are above 40, and we do the prostate-specific antigen for males who are more than 50 years old. We also pay a particular attention to immunological risk in patients. And so we assess the ABO compatibility, we evaluate for HLA mismatches in patients, and we test for the presence of preformed anti-HLA antibodies, and then we do cross-match testing, all in a bid to evaluate the immunological risk of the patient, and we take appropriate measures to minimize the risk. Finally, the multidisciplinary team assesses the patients, and usually the team is composed of nephrologists, transplant surgeons, nurse coordinators, social workers, psychologists, and other members. And the team reviews the risks, the benefits, and patients' expectations. The team identifies and determines the best options and facilitates transplantation. Also ensures that everyone managing the patient is on the same page, and that the transplant process is done seamlessly. And it's only when the team is satisfied with the patient and the recipient, that the patient is deemed acceptable by the team, that is when kidney transplantation is allowed to proceed. I thank you for listening. Thank you.